Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Doctors Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz Podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Hello and welcome back to the Fuller Butz Podcast, a behind-the-scenes look at plastic surgery. I'm one of your hosts, Dr. Sam Fuller. Joining me is Dr. Dan Butz from Milwaukee, Wisconsin. How are you doing, Dan?
I'm good. How have you been?
Busy, end of the year, getting cases in, trying to squeeze as many packed cases, combo cases as I can into the schedule. How are you looking as the holidays and the winter time where most of the makeovers and plastic surgery seem to be in full swing?
Yeah, it's definitely kind of busy season, fall, gearing up into winter. Everyone kind of wants to get it done either, before or right after a holiday when they kind of have some vacations or extra people around to help out. So yeah, super busy. New partners are getting busier. It's been great.
Yeah, I just had a tox party last week at my office, sort of themed, big group, just showing some of the nuances of what tox can do. Still, it's just that powerhouse treatment that works, that's reliable. And then, having some great consults this week for patients who are looking to combine different procedures. Do you have any interesting cases or combined procedures that you're looking forward to in the next few weeks?
Yeah, I mean, been doing a lot of tummy talks at a nice fleur-de-lis, abdominoplasty last week with fat transfer. I've been doing a lot more fat transfer to the breast actually than average. Still doing way more implants than fat transfer, but I think I've been using this newer device that kind of has been shown to help to have the fat take better. So excited about kind of seeing some of those longer term results. And just trying to give patients who don't want implants some extra volume at the same time.
Well, what a coincidence!
That's
our topic for today. We're talking about fat transfer, amongst other things, for the treatment of hip dips. And so our title of this episode is Hip Dips and Lip Flips. And we thought that as those being sort of combined adjunct procedures to other combined procedures, we really wanted to get into the nitty-gritty as far as what those are, what are ways to treat them, just because it seems to be more and more a popular choice and item, a discussion that we're having with patients who are having body contouring or even just tox procedures in the office.
Yeah, so really kind of you were talking about your Botox parties, which is, some people think of lip flip might be using fillers when it's actually toxins. We'll talk about that more in detail. But we'll start off with hip dips, and Sam, we want to just kind of explain what a hip dip is, what causes it, and are there any other terms that might be kind of misleading or confusing about this?
Yeah, and so hip dips, when we talk about hip dips in plastic surgery, we're really talking about I would say, natural anatomy of the hip. You have the pelvis, and you have your hip, where your waistband sits, where your love handles are. And that's really the pelvic rim. And then when you start to run your fingers down your leg to the next bony prominence, that's the greater trochanter of the femur, or your long thigh bone. And there's a depression, or there's a natural space there where there's there can be either from weight loss, from pregnancy, or just normal anatomy, where there's just a lack of fullness in that space that's on the lateral side of the butt. And so when you're looking at yourself, looking at other people in bathing suits and pants, it can be sort of unpleasant divot or depression on the outside of the butt that many patients are wanting to address in today's world of plastic surgery, social media, and body image. Looking back in the 90s, it was ultra thin. Into the 2010s, it was bootylicious, high curves and large and in charge. And now I think we're sweeping back to more natural looks, and hip dips is one of them. Another term that I've seen is also called like violin hips. And you just think about the natural shape of the wooden instrument of a violin, where you kind of have those curves, and you think about the hip, and then you think about your thigh bone, and that depression on the violin is what the hip dip is. Dan, does that make sense as far as the topics of hip dips and explanation? Would you define that or characterize that better? We'll pop up an image for our listeners who are watching on video for us too.
Yeah, I mean, I think you nailed it on the descriptions. I haven't actually heard the violin term, but it totally makes sense. And you see, a lot of this is just natural anatomy, and I think a lot of Instagram posts. Sometimes you see some before and after photos of a patient posturing and posing. Kind of nice posing often kind of hides it. So, if you either kick out a hip a little bit differently or a little bit bend, it kind of fills that in and makes it look round, which is what these procedures are often, we're doing a target to try to fill that area in, so that it doesn't require as much kind of deceptive, posing perhaps.
Yeah. So, while it may be exaggerated from weight loss or, other things, I don't think it's a new problem. It's something that's always been there. Dan, can you tell us, what are some options? What are some non-operative, specifically like non-surgical options to try to correct this depression if people find that to be unbecoming, or they're dissatisfied with the lack of fullness on the outside of their butt/hip dip?
Yeah, so if you spend a lot of time on Instagram, where people are always kind of maybe I'm just getting targeted with this for some reason, but there are workout programs that are targeted to fill out the butt in different ways. So really targeting the gluteus maximus and medius muscles to kind of help improve that shape. How well those actually work are probably hard to prove. There's not great data, but in theory, targeting certain muscles could improve that concavity, but probably not eliminate it altogether. There's certain devices, non-surgical, energy devices that stimulate the muscle, like mSculpt, Cool Tone, that are designed to target those muscles and make them larger. It's relatively temporary to kind of continue to maintain that, like any muscle growth, like going to the gym. This kind of is a little bit of a shortcut in that sense. That's also advertised as kind of a non-surgical BBL, where it kind of lifts and gives you more projection as well. And then, it's still non-surgical, but there are injectable options. People have talked about using hyperdilute radius, which is a kind of biostimulatory, or Sculptra, same kind of concept, where you're kind of stimulating the body to make more collagen, which adds volume. This tends to be a pretty, slow process and require, quite a bit of product. So unless you have really, no fat and, it's oftentimes end up more expensive than surgery, but it can plump things up. There's a newer, kind of it's like a dehydrated human fat that is ready to inject, called Alaclay, I believe. Have you heard about this product? It's similar to other. It's just kind of coming up. People are doing studies on it, but have a lot higher volume than some of the other ones. 12.5 to 25 cc's, kind of ready to use. And early reports show that it's quite effective and lasts a very long time. So still too soon to be too excited about that, but definitely has some potential. So we're surgeons. Surgical options generally work better in the long run, but obviously have different risks. I mean, Sam, tell us a little bit what the best surgical options are for this area.
Yeah, and correct me if I'm wrong, but if we're talking about a patient who's dissatisfied with their hip dips, and you kind of go through all of those non-surgical options, hyperdilute fillers such as radius, muscle tone, are you giving them high expectations, like, hey, yeah, this is going to fix it? Like, what's your tone with those types of options? Because for me, I find those to be somewhat limiting. They're not sustainable. They can be, as you mentioned, costly or just even more expensive than surgery. And I can't promise that this is going to totally correct and erase their hip dip in these non-surgical options.
Yeah, for sure. I mean, the nice thing about injectables is that it's often like a slow growth. So you do a bunch of different vials and kind of wait and see how it responds, and you can do more, but it gets pretty expensive. And even, the best results are, relatively subtle and last maybe, 3 to 5 years is what, these products maybe work off, when it's in the body, versus the face where normally it's like 1 to 2 years. But yeah, it is non-surgical. In this newer fat product, we don't have a lot of data on, and then the M-Sculpt, whatnot, requires a lot of maintenance. So yeah, normally it's kind of it can improve it, but it's not going to be, amazing. You might probably need to augment it with exercise and doing some of these other things to try to make it as good as possible.
And as Dan and I were
talking, as much
talking,
control when we're not doing surgery.
yeah, and as Dan and I were talking offline briefly about, options, surgical treatments, non-surgical, we want what's best for our patients. We want it to be safe. We want it to be cost effective, and we want it to be sustainable or lasting. And so those are, some of the key priorities that we put into place when we're talking about hip dips and just, surgeries in general. As far as surgical options to correct hip dips, I would say that the gold standard, or really the workhorse, is fat transfer. And using one of the commandments of plastic surgery, and one of our mottos is the use of spare parts. Whether it's a mangled hand or using extra skin and other things. What we've found is that it's very convenient to correct the hip dips at the same time as doing other body contouring procedures. For instance, if you're doing liposuction, either on its own or during a tummy tuck and abdominoplasty 360 liposuction, you're taking fat out in places where the patients don't want it. And in order to really accentuate and to make things look even more natural, more sleek, more aesthetically pleasing, we can actually retain that fat, spin it, treat it, and then slowly inject it back into that hip dip area to really form that shape on the lateral buttock. And that's not the same as a BBL or a Brazilian butt lift, where we're trying to maximize and put as much as we can, but we're really trying to correct that natural anatomic phenomenon of having that deficit of volume that's in that hip dip area. And so fat transfer to me is really the mainstay surgical option. Now you can do butt implants, you can kind of rotate, move tissues over, but I would say fat grafting or fat transfer to that area is certainly my go-to. Dan, can you take our listeners through like what the steps are for fat grafting or fat transfer? Because it's not just like we suck it into a bottle and then we just re-inject it. Like there's more to it than that, because we want to make sure that it's safe and clean and it's going to last.
Yeah. So, again, like you mentioned, liposuction, fat transfer is kind of this great 1-2 punch. You're taking fat from areas you really don't want it, and improving those contours and putting it in places that you want more fullness. But absolutely, you need to handle the fat properly. There's a lot of different methods of doing that. I think most of the data now is someone trying to do some kind of closed technique where you're collecting the fat into some sort of canister, then you wash it with lactated ringers to help get rid of some of the little bit of blood that's around it and some of this messing agent, really clean it in some of the oil. Some fat cells get damaged, and we want to kind of get rid of those, and then get it as kind of purified fat as possible. So you're really injecting as clean and not a lot of these inflammatory agents at the same time. Then that fat is transferred either into syringes. Sometimes you can, for larger volumes, kind of power inject. And then injecting it kind of in small aliquots throughout the subcutaneous layer, the fatty layer, to fill in those defects. And as much as it's kind of targeting different things, it's very similar to BBL. And some patients, sometimes when I mention this, they go, "Oh, I don't want to be," they think they hear the term putting fat near their butt is like they're going to get some big disproportional kind of result, and it can be very tailored to their anatomy, their goals. And really targeting, again, kind of create more of that S shape instead of the violin kind of deformity in the hips, really specifically targeted, not looking for just mass volume. So does that kind of, you think I missed anything there with fat transfer? Does that explain it well enough?
No, that was
a lot of nuances. you could get.
Yeah, there's different systems. The system that I use, I think we both use or have trialed it, uses actually surfactant that's in the lungs. And it was found that if you rinse the fat with this surfactant, it actually has longer viability and survivability to the point of they're actually doing 3-dimensional imaging a year out in patients and studies and having over 90% of the fat maintained or retained at the recipient site, meaning that in our training, we were kind of saying, hey, 50-50, you're almost over injecting, trying to put more because some of it's not going to last and it's going to get reabsorbed, into now where we can be pretty meticulous and putting in the amount of fat that we want to and be fairly reassured that majority of that's going to stay where we're placing it. So that's great for our patients, and just decreasing the degree of uncertainty. As far as like how much fat we need to inject into these areas, I do think it's kind of on a patient by case basis. So I wouldn't say there's specifically like a number that I do for every single patient. It's totally dependent on how much fat they have, how much fat we can harvest, and then how big of a hip dip they have. As I'm thinking about it and visualizing it, marking them in the pre-op area, they may have a sizable love handle. They may have a lot of fat on their flank area. And simply by doing liposuction in that area, you're going to decrease the visibility. It's almost like a visual illusion where the hip dip doesn't seem as prominent. And so if you take some of that down and then you put some of that back into that hip dip area, you just create a more hourglass figure, just more smoothness and more of a just aesthetically pleasing flow from side of body to, buttock to hip down to the leg. And so, I'm not necessarily saying, oh gosh, I'm, looking at a hip dip and saying that needs 125 cc's or whatever. But I think it's on a case by case basis. I try to be as symmetric as possible. Everybody's body is asymmetric. And so some patients may have more of some asymmetry on one side versus the other. But the goal would be trying to make something that's very symmetric to fill in, to give it that natural beauty and not the Kardashian, oh, I'm going to overfill this area. We want it to really stand out. And Dan, do you have that same kind of thought process, whether you're doing saddlebag liposuction or flank liposuction, right around this area where the hip dip, where you're really trying to smoothen out and create a more natural, smooth contour rather than step offs and divots?
Yeah, absolutely. And I was going to say the same. You mentioned the love handle area. The saddlebag kind of really tends to make hip dips look a lot worse. So bringing that in a little bit and then bringing out the hip dip can really improve the whole contour. So it's all about trying to get that smooth shape and roundness. So if the fullness above and below, it's like addition, subtraction. You want to subtract from those areas and add in the kind of depressed area. There's no special number formula. Everyone's anatomy is different based on their kind of baseline foundation, what we're starting with. So some people need more, some people need less. And you're trying to just tailor it to their body, their goals.
And so Dan, a majority of my cases that I do this in, it seems to be a combined case where it's, they're getting a tummy tuck, they're getting, liposuction. Let's say that, you have a patient who's going to have a tummy tuck, you're going to do liposuction, and then you're going to try to correct their hip dips with fat transfer. How does that change the recovery process for a tummy tuck? Or, are there different restrictions? Are there, can't lay or sit? What are you telling your patients, and for how long post-op are there restrictions or changes to the recovery?
Yeah, the key thing with any fat transfer is trying to avoid too much compression in the area. So you don't want to squish it, flatten it, compromise the blood supply. So the nice thing about adding hip dips to a tummy tuck is you're already recovering on your back. The hips are on the side, so you can sit on your butt just fine and not really have to worry about compressing them. It does limit your ability to kind of turn onto your side, which normally isn't. Most people don't feel comfortable with that till maybe a week or so, anyways. But we don't want to do that for probably at least the first 2 weeks. That's really the biggest difference. Probably maybe a little bruise there, but doesn't really add too much to the discomfort or the recovery at all. So pretty relatively easy add-on to that kind of surgery for sure.
Do you have extra incisions for fat transfer to the hip dips? Like what extra are they going to see on their bodies as a result of this?
Yeah, it kind of depends. I mean, sometimes depending on where my tummy tuck incision goes, sometimes you can reach it from that, but most commonly I add a small one kind of just above it to, fill it in from the front. Occasionally, if it extends more posteriorly, maybe I'll put it in from the back before the tummy tuck to kind of try to fill in the tail a little bit, but not, doing too much volume centrally. What about you? How do you approach that?
Same thing. I would say that in very, fortunate cases, sometimes I can get to it from the abdominoplasty incision, but more to be as accurate as possible. I'm making a small, port site entry point stab incision where it's going to be one single stitch with a little Band-Aid over it. Not going to lead to any additional scarring, but it's just going to allow me to really in a lattice-like format, just slowly and intricately put the fat in over and over into a very, localized space to be as accurate as possible. Extra little Band-Aid, single stitch, but not much differences. Same thing with lying on your back. You're doing it anyways. Doesn't really change the recovery that much. But I've had some patients who, have had breast implant exchange, breast lift, tummy tuck, 360 lipo, hip dips, and the patient and their husband come in at 6 weeks and they're like, the hip dips are my favorite part. Like, this is just amazing. I'm at the pool now and I just don't worry about how this is looking anymore. So I think it could really be a game changer for a lot of patients. And I think one thing that we've haven't really touched on is why we like fat for that area, and rather than filler and M-Sculpt and some of the other options, is that it can be a permanent correction. It can be something that stays there forever. Fat is a living part of your body. So if you lose a lot of weight, that fat can go away. If you gain a lot of weight, that fat can increase. But that's something that could be a long-term solution. Dan, what do you tell your patients as far as having to go multiple rounds of fat transfers and fat grafting into specifically the hip dip? Is that something that you're doing, multiple rounds of fat transfers, or you tend to get it right the first time?
I think with hip dip, since it is, like you mentioned, a little relatively smaller volume than say when we're trying to, augment the breast or the butt, I think one stage is normally adequate. So, anytime with fat transfer, because there are those variables, regardless, I say there's a chance you might want a second stage. But, again, utilizing this newer system that has a higher fat take, plus, again, the area tends to need less and less potential for that. Would you agree, or do you think it's...
No, I completely agree. I have two kind of just questions, more for me than anything. At what point during a tummy tuck are you going to transfer the fat? Obviously you do the lipo first, you spin it, you figure out how much you have, you place it. Are you doing it at, once all the skin is closed? Or are you doing it before you sit the patient and flex them in order to get the upper incision to close? At what point during that, kind of complex multiple hour procedure is the fat actually going into the hip dip area?
I tend to do it towards the end, maybe not fully closed, but, maybe flaps, advanced, deeper layers are done. We're maybe starting to work on the final layer, but, then, do that, I don't want it to be the last thing I do, but, kind of, get that shape just right. And then kind of do my final closure. I think that just works well with the flow. We're getting the fat out, they're processing it. We're doing everything else. I don't like sitting doing nothing during surgery. So if they're processing, doing something, I can be, doing other procedures or other parts of the procedure. So that way it kind of just keeps everything moving. Nice flow to the surgery. Is that how you do it, or what's your thought?
Yeah, I usually have, my scrub nurse start working at it, cleaning it, rinsing it as I'm, moving on, just for efficiency of the case. And then once we have it into syringes, we kind of know how much we have and how much I was anticipating using. I definitely do it while the patient's still flat, or we can kind of turn and roll and find those areas that I've marked preoperatively to find them. I find it to be difficult when you have already flexed the patient up, closed their skin, and then you're trying to move them. It just is more awkward, more at an angle to get the fat into that area. So I'm towards the end, but before I'm flexed up and in a tighter spot, because sometimes patients flexed up quite a bit in order to get that drainless tummy tuck looking snatched. I have one other question for you, and it's something I kind of grapple with. In the office, are you pointing this out to patients every time? Are you waiting for them to bring it up? Because kind of lost because some patients that I pointed out to, I feel like they're enthralled and like, I didn't even know that was an option. Yes, I don't like that. Let's do it. Let's fat transfer. But I also don't want to just be a pushy product, pusher where I'm saying, oh, do this and do that, and trying to get all these add-ons, like where I feel like it's aesthetically pleasing. I'll suggest it, but I'm certainly not, offering it to every single patient. Like, where does your practice and your consultation lie as far as, how much discussion and how much are you waiting for patients to bring it up versus you offering it as a combined portion for these cases?
I think, yeah, it can be a little touch and go. I don't have a lot of people directly asking about it. But if they're complaining about not liking the contours of their back, and maybe they mention those saddlebags, I'm like, oh yeah, we can remove some of this, and if you'd like, we could fill a little bit in here. Kind of just mention it. You're not in a pushy way at all. Just kind of saying this is an option. If they're like, oh no, then I don't mention it again. It's like, oh, that's interesting. Then we talk more about it. That's kind of like the part of the consult is to educate on what these different options are. Again, a lot of people aren't really familiar with what they all can do. But I don't, tend to go out of my way and say, oh, you really need to do this. It's gonna, it's a nice add-on, but it's not, typically it's not the make or break of the procedure for most people.
Yeah, I had a very patient-driven conversation, and actually next week I'm doing a wonderful 360 lipo drainless tummy tuck with Avoli cellulite treatment for some creases, some folds on the thigh, and then also with fat transfer to the hip dips. And it's really just going to be, I think, a huge game changer for that center of mass that the flanks the body is just, she's a perfect candidate for that. And that was something that was bothering her. So it was just a natural trend of having all of these procedures work in different ways to sort of stack the results in our favor.
Sounds like it'll be a good one. Should we move to the next topic?
Yeah, I think we're dipped out. Yeah, let's flip some lips now. So, I would say that there's a lot of people who probably don't know what a lip flip is. So, Dan, can you tell us what we're talking about as far as a lip flip?
Yeah, so, obviously in the last, 10 years or so, lip fillers have become very popular, trying to make the lips look bigger. But some patients don't really want big lips, but they want more red lip show. So relatively nuanced and not all that as common or popular procedures, using a very small amount of Botox kind of just on the edge of the lip to relax the orbicularis muscle that wraps around it. And as it relaxes, it just kind of opens it up a little bit so you can see more of the red lip. So you can make the lip look fuller without actually making it bigger with some of the potential side effect, less than optimal effects of fillers and lips that they look too big or kind of fake. So it's like 6 to 8 units of Botox. So it's very small dosages. And how long is that typically? What's that?
Or Jeuveau or other tox companies.
I shouldn't drop name brands here. Whatever neurotoxin you're biased towards, they all work. What are your thoughts on this versus fillers? Any pros, cons, potential side effects?
Yeah, for the right patient, this could be a game changer for a lot of reasons. So I would say a perfect candidate is someone who either has a gummy smile, meaning that when they smile, their upper lip really disappears, or they're showing their gums as well as their teeth. That's sort of that term. And it's been found to actually, kind of soften that smile to allow some of that upper lip to show, to puff out and make it pouty. So there's some functional benefits by injecting some tox into the upper lip. It's also beneficial for patients who have some vertical lines on the skin just above their lip. That's also called smoker lines. Those can be softened with the use of just a few units on either side of the upper lip. And then just patients who either just don't want to spend the money for lip filler, don't want to have that risk of significant bruising, swelling, of that duck face, and just from a cost standpoint, it's a lot cheaper than filler, and it could give you the results that are natural, but still with more of that upper lip show. So I'm a huge fan of it. I do think that the unit differences vary from person to person. And, I usually start very low, either 4 to 6 units total, and then have them come back a couple weeks later and add 2 units, just to find the final working point. Just because there are risks, associated with over paralyzing those muscles above your lip. The inability to drink out of a straw, to whistle, to, kind of have some, biting your lip, things like that are some drawbacks from that. What do you feel like are the main advantages of lip flips versus filler? And, do you see this combined with other treatments, of the face when, patients are asking for this?
I mean, routinely you're getting toxins, a lot of different places. So often adding on 4 to maybe 8 units is a real, it's kind of part of the treatment strategy. And I think most patients either fall into, wanting one or the other. Some people like lip fillers, like that fullness, but a lot don't, and are kind of worried about some of the potentials of overfilling the lips. And this is kind of a nice way of giving you a little bit more show, or addressing some of those other kind of concerns that you mentioned in terms of smoker lines or gummy smiles, while also kind of improving the appearance. So, how long do you typically tell your patients that it lasts for? Is it kind of like other Botox treatments, 3 months, or?
Yeah. The box label says 3 to 4 months or 90 days. And so I would say it's 3 to 4 months. If patients are naive to that, it can last, of course, longer. It varies from person to person, but I just did a bunch of lip flips at this tox party I alluded to at the start, and patients love it. It's every 3 or 4 months they're coming back. And, with some products that work quicker than Botox, like Jeuveau, which is one of the products I use, within a couple of days, they're sending me their after pictures with their pouty lips and, just feeling really good about having that upper lip show, as opposed to, going through the course of filler. So I think for the right person, it's great. It's not going to fully replace volume. It's not a true filler. You have to sort of temper expectations on what the capabilities are for the tox, not magic, pixie dust that we're doing. But typically about 3 to 4 months of activity is what I would tell patients. And then if it's not lasting as long, increase a couple of units on each side. Don't like it, there's not an antidote, but you have to kind of wait it out. One of the patients from my tox party I saw today in the pre-op area, she's in the medical field, and she's like, I can't whistle. It's working. I love it. Oh my gosh. I know it's good when I can't whistle. And I'm like, you're okay with not whistling, right? And she's like, oh no, that's when I know I'm at the right dose. And she was like in love with it. But, there are some changes, if the muscles aren't as strong in that area, but it's certainly not going to impair you from speaking, from eating, from, chewing, from talking. No one's really going to know that. And if you're not required to whistle for work or for other situations, it's probably not a big deal.
Yeah, as much as it's maybe more frequent than lip fillers, every 3 to 4 months versus 9 to 12 months, it's like you mentioned, a couple little needle pokes and there's always a chance of bruising, I suppose, but very low chance of bruising and not a lot of swelling associated with it. So a little bit easier treatment to have, even if it's a little bit more frequent and less expensive.
Yeah, usually two injection points on each side, just, along Cupid's bow, just at that vermilion border into the skin, just above the lip. And so I usually do that last. It's a little bit sensitive, but just 2 small sticks, very localized to that area. But yeah, it's a great option for patients. Lip flips, combined with other tox treatments, fillers, very few side effects, something that's there, especially where I feel like the big, huge lip phenomenon seems to be less. Like even in my practice, I feel like I'm using less filler. And so I think the lip flip may be becoming more common in that patients want that little touch up, that little perk without the extra, almost unnatural look that filler can sometimes create. But, I never really want that look for my patients.
Have you seen lip lifts? You ever seen one of those?
Like the surgical
little bullhorn of skin below the nose? It's a
Yeah.
pretty, I don't do face surgeries anymore, but it's a pretty cool little surgery that can, given a similar appearance, in the right patient, sometimes as we get older, you get really elongated upper lips, and shortening that can, give you more lip show, and just, make things look, a little bit more proportional. It's not something I do, but my partners definitely do. I've seen a number of those. It can really make a big improvement. Again, permanent kind of lip flip in a sense.
Yeah, that would be lasting, something that, could potentially correct that without the need for continuous toxin fillers. I've showed some patients interested in that, some pictures, and they're like, no, thanks. I don't want to risk that scar that's just under my nose. So I've not performed that. I'm not seeking that out. I think you really have to do some good calculations, some math as far as making sure that skin is going to pull down and really be secured down into that junction between the base of the nose and the lip. But yeah, those results can be incredible in the right hands, for sure.
Yeah. What else? What else do we have? That was a fun little topic. Hip dips, lip flips.
Hip dips and lip flips. I think that, we covered a great amount of information. I think we should, probably wrap up. We don't have a guest this week. That's kind of a downer. I'm sure, some people are disappointed just to hear our voices. I'm looking at you. I feel like, man, we do look a lot alike today for some reason. But hopefully we can get some guests on and continue to just choose different nuances within plastic surgery, different subtopics, and divulge as much information as we can behind the scenes for plastic surgery to educate, inform. And I think hip dips is one of those things where, you tell a few people and you start to educate your patients, and a lot of patients are, didn't know that something could be done for that, especially for something that's so minor. We're taking the fat out anyways. Why not use that spare part, put it back in? Doesn't change the recovery all that much at all. And something that can be a very dramatic result in that visual appearance of the shapes of the hips, the butt, the flanks as we're doing these body contourings for all of these wonderful patients of ours.
Have you had any patients, when you mention it, say, I don't want my butt any bigger or hips any bigger?
Yeah. And I have. And so that's kind of like a quick conversation.
Yeah, right.
Even if I'm trying to say, well, we're actually taking it out and we're just repositioning it, it tends to be like, that's not right for me. And
I think most people are happy with it in the garbage, but it's good to know your options.
Yeah. Or I have like their friend who's with them being like, well, you could take my fat. And I'm like, we can't use other people's fat. But maybe with that off the shelf fat that you mentioned earlier as an option for patients who maybe don't have the fat to transfer, who, are having the surgery, having a tummy tuck, really don't like their hip dips, but we don't have sufficient fat. Maybe there's that new science, that new technology that's going to be available. Certainly I want to see some long-term studies, some results, what the cost analysis is, what's the safety on that. But it seems like there's lots of options. And as this industry continues to move forward, we'll continue to have to interrogate and stay up to date on everything that we're doing. Yeah.
Awesome. Well, good luck with your big case next week. That sounds like it'll be a good one. Make sure it'll get posted on Instagram at some point in time.
For sure.
And yeah, we'll catch up soon.
All right, man. Take it easy.
See ya.
Bye.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButtsMD. That's Butts with a Z for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.